So everyone can see that all right? I don't see one of our co-presenters, Dowin, in the room yet. If he does come in, could you, either Gary or Marty, can you just let me know? He is an emergency medicine doc, so he could very well be tending to an emergency. So thanks for having us today. We're excited to lead this discussion. We really want to make it discussion oriented. The topic is awareness of biases in assessment and ways of addressing them. My name is John Encandela. I'm a member of the Teaching and Learning Center at the Yale School of Medicine, as well as my co-presenters who are members of the center. I'm associate professor in psychiatry. My background is in sociology of medicine. Spend most of my time in the Teaching and Learning Center focusing on directing curriculum and educator assessment. Marty?
Hi, I'm Marty Slade. Great to see you all. Also in internal medicine. Spent a lot of time with the TLC, but I also am director of research for occupational environmental medicine.
Great. And don't think Dowin's on yet, is he?
Oh,
Yeah.
I'm here.
Oh, you are? Okay, great.
I'm Dowin and Boatright. I practice emergency medicine, and I'm a part of the Teaching and Learning Center as well.
Thanks, Dowin.
Okay. Can I help you with anything?
I think we're good. I'm going to turn it over to Dowin to get things started.
So today we just wanted to quickly focus on the learning objectives we'd have. And by the end of this workshop, we expect all the participants to be able to recognize some areas of potential bias in both qualitative and quantitative assessment for both students, trainees, and faculty. Additionally, we intend to be able to identify and reflect upon approaches to mitigate these biases in assessments. And to focus again on what we intend to discuss today, we really want to emphasize unconscious or implicit attitudes and belief. These are often acquired without an individual's awareness, but can still influence the judgment, decisions, and actions without particular intention. Again, these can be directed towards entire social groups and the way we think about individual members of those particular groups, including trainees and faculty. Of note, these implicit biases and beliefs are malleable and can change even in the absence of active attempts to persuade individuals. In fact, even changes in the local environment can produce corresponding changes in people's implicit attitudes and beliefs. The presence of bias in both qualitative and quantitative assessments has been well documented, and here are just a few studies just within the last few years. Of note, one study actually conducted here at Yale. One of the things we want to emphasize is that gender bias in narratives often are present such that men are identified through their knowledge, skills, and abilities with the use of standout words such as best, excellent, and outstanding. One particular example is he exhibited a great deal of knowledge about the biological basis of clinical decisions, where his dexterity in complex surgical procedures is outstanding. This is in contrast with women who are often identified through grindstone words such as hardworking, or a focus on their personality or interpersonal traits, such as she puts in 110% effort in all that she does. We see also disparities based on race ethnicity, with students of color being more likely to be, or less likely being described with superlatives such as best and brightest, and students of color and women being more likely to be described with faint praise or minimal assurance with words such as competent. I'd now like to turn over to John, who will discuss in more detail some of the studies that have shown these differences.
Yeah, so I want to point out that Dowin was a member of the team that did an assessment of MSPEs, the Dean's Letters at Yale. So you might want to pick his brain about, about that study. But I want us to take a look particularly at the study by Rojek and others. A pretty comprehensive study. And I know that some of you are here interested in thinking about ways that you might help faculty in their narrative assessments of trainees, and maybe even address narrative assessments of faculty and teaching evaluations. But I know that some of you are here, or maybe all of you are here also, to think about how to conduct research on narrative assessments. So I want to take a little bit closer look at this particular study. So this was a study that was conducted at University of California, San Francisco and Brown, so 2 medical schools. And it was a study of whether there were systematic differences in language used in narrative evaluation of female identified and male identified students, and between students who are underrepresented in medicine, URM, and those who are not underrepresented in medicine. And for the purposes of this study, URM is defined, and it was defined on both campuses, as African American and Black, Hispanic and Latinx, and American Indian and Alaskan Native. Any other ethnicity or race that was designated in the evaluations were considered to be non-URM. There were almost 90,000 evaluations of clerkship students at the 2 schools. So a large number of evaluations. At University of California, it was conducted between 2006 and 15, and at Brown between 2011 and 16. I think at Brown, there was a major change in the assessment approach, so they got started a little later than they did in San Francisco. The data that was collected was about gender, about URM status, and grade status was also collected. At both institutions, the grading in clerkships was honors, pass, and no pass. There were so few no pass at both institutions that for the sake of analysis, the study included honors and pass. So you see in this chart, you have honors and pass on the y-axis, and we're going to first look at women compared to men in just a second. But just to finish the background in terms of how the study was conducted, the investigators used a trained English language parser that's available free from Google to parse the frequency of language used. And they also used a natural language processing method known as term frequency inverse document frequency, or TF-IDF, to adjust frequency of terms used with how rarely terms are used across all the evaluations. So there was a weighting process that occurred. And what you're seeing on the screen are terms that emerged that had significant difference at the 0.05 level in usage of terms. In this chart by gender, and in a second, we'll look at the chart on URM status. So I want us to take a minute to look at just the side on female identified adjectives that were used and that were used in that emerged as being significant, statistically significantly different than the terms used for men. So what are you seeing in this side of the chart? Anybody can chime in.
Personality traits.
Somebody is saying personal qualities. Yes.
Soft and fluffy.
Say that again. I'm sorry.
Soft and fluffy type.
Oh, yeah,
of
fluffy.
analogy.
Yes. So if you look at the y-axis, the points that are closer to the honors were obviously more frequently used when describing trainees who received honors. So you see things like efficient and wonderful closer to the honors end of the axis. Pleasant is the only one that really falls below, and those that are on that fall on the along the x-axis had no specific distinction between honors and pass. Other things that people were seeing, lovely is a word rarely used for men, somebody says. Stereotypically superficial, someone else says. So I think you're getting the point. Now what I'd like to do is look at the terms used to describe men more frequently, and tell me what you're seeing here. Anybody? Somebody is saying that it's difficult to remediate when terms have to do with personality, really. And are you seeing terms that have to do with personality on both sides of the y-axis? The x-axis, I mean.
Ernest.
I'm sorry. Say that again, please.
Right.
The humble, earnest, relaxed, easygoing seems he's probably better than portraying himself.
Polite is something that may be referred to women as well.
Yeah. Terms for men have more to do with being an effective doctor, which I think is true. What is interesting about this chart is that I see terms that portray personal traits on both sides of the axis. So maybe the big lesson here is that it's okay to talk about some personality traits, but if narrative assessments are overwhelmingly about personality, where does competency come in? And that's where, that's what I think program directors and others who are looking at these evaluations are going to be concerned about is competency. So there isn't a whole lot of competency-based terms on this chart for men or women. So maybe that's one big lesson for all of us. But there does seem, as one person pointed out, to be a bit more on the male side that have to do with, or at least insinuate some competencies. So that's one difference that I'm seeing. Another person says less emotional definitions. Another says how are personal traits related to professionalism. I'm going to move on to the next, which is looking at URM versus non-URM. So this chart looks a bit different from the last one in that there's a lot more adjectives on the left side than there is on the right. So again, I want us to look at what we have on the right side, those describing those who are underrepresented represented in medicine. What are you seeing here? Anybody?
No high honors.
Yeah, so there, I don't see any words that are frequently used in the quadrant of honors on the URM side. Does that mean that there aren't a lot of honors, or does that just mean there weren't frequently used terms across the evaluations? I don't know exactly, but it is curious. Cultural and native, these really stand out to me. Somebody says nothing about medical knowledge, absolutely nothing about medical knowledge, actually. No intelligence related terms. Somebody says while, not very helpful evaluation words. And then one person says Spanish, question mark, exclamation mark, which I agree with that. It could be though, and I think this might be one of the drawbacks of the study. All studies have them. It could be that that they were pointing out, the assessors were pointing out something about competency if they were saying, the fact that this person speaks Spanish and could speak to native Spanish speaking patients might be a competency. So I'm not sure about that, and we don't know that from the evaluation, but this particular term could point towards a competency. We just don't know. So that is a drawback, I think, of the study. Now let's look at the other side. So many, many, many more terms. What are you seeing here? besides many more terms. Superlatives again. So one of the lessons might be that across the board, we need to think about competency-based language rather than superlatives and personality-based language. Some of these get to competencies. What strikes me about this is, so somebody does say more focus on clinical competencies. What strikes me about this is if you look at the upper left-hand side, words like excellent, medical, which I assume is associated with competencies, outstanding, best, and exceptional, I think all could be associated with competencies, and words very frequently used to describe those students who received honors. And then blank on the right-hand side. So what I'm getting from this particular study is that, that people who are identified as underrepresented in medicine might actually be hurt even more by the language that we use than what we saw in gender differences, where there were definitely differences, but the major difference was that it seemed like everybody used superlative and personality-based language. Here, I think we're seeing a big difference in the way in which people who are not URM are described versus those who are URM, and very, very few terms that are used frequently, which again might mean that the individual evaluations might be very individual and unique. We don't know that in particular about this study, but I do see a stark difference in terms of how language is used. Does anybody want to say anything else about this before we move on? So let's think about some tips that we might use to improve or to reduce bias or get rid of bias altogether. And these, I think, are really geared towards if you are individuals who actually help individual faculty assessors in thinking how they write their narratives. I think these tips can be very helpful, but I think there's another set of tips that we might think about, and maybe you'll get to talk about when we go into breakouts in a minute, that are more systematic, that may create change at a systems level rather than trying to reach individual assessor and trying to make their evaluations better. But let's take a quick look at these. So one is to bring unconscious bias to the level of consciousness by having the individual assessors reflect on what they wrote, maybe having an objective reader and maybe a blind reader, not knowing who the student is, read the evaluations for the sake of eliminating bias. And maybe this could be done on a, rather than on an individualistic basis, could also be done on a systematic basis. And the second is to check and replace biased language. So really focusing on language based on performance in areas of knowledge, skills, and abilities. And we really didn't see a lot of that across the board in the evaluations terminology that we looked at just a minute ago. So something like, even if you do want to point out some personality traits or some things that are really nice and good, there are some of those terms about the trainee, maybe couching those personality traits or those really good characteristics in terms of competency and skill. Like, she has a keen skill in understanding what a patient says and feels, and communicates this understanding to the patient as a way of both checking the accuracy of her understanding and helping patients feel at ease, rather than saying just she's very empathetic with patients. So there's a difference there, getting some language of competency in while still pointing out the personal traits that are really helpful in the clinical setting with patients in that statement. Be consistent when using language to point out areas for improvement and deficiencies. So if you say something like his basic patient interviewing skills are good, as next steps, he should concentrate on spending a little more time with a patient-centered approach, etc. If that's what you say with reference to one person, but then with the other person with the same, really the same set of competencies, very comparable, he needs more work on patient-centered interviewing and a smoother transition into the clinical focus portion of the interview. This is a stark difference from what you said about the first trainee, who's really comparable in every other way to the second trainee. So really checking, maybe checking across the evaluations that you write to make sure that there's consistency in people who you view as being comparable in skills and performance. And also when actually pointing out very positive things in the graphic below, use the same terms to point out things that are good about the trainees across the board as well. So maybe cross-checking across your evaluations may be a good approach as well. Avoid cliches as much as possible. There are very often biased, gender-based and other kinds of biases embedded in cliches, like went over and above the call of duty, perhaps say excelled, or took on the Herculean task, Herculean being very gender-based in and of itself, say something like perhaps use very capably handled. Now I'd like to have us go into breakout rooms. Gary's gonna actually put us into rooms in just a second. I see we have about 100 participants, so I think maybe 10 or 11 rooms, maybe 11 rooms with 8 or so people in them. And what I'd like you to do is to have those who are in even number breakout rooms focus on case 1, and those don't want to confuse you, odd number breakout rooms focus on case 1, and even number breakout rooms focus on case 2. So when you get into your breakouts, assign a recorder, have one person read the case aloud, and then discuss what you would do in order to make the case less biased. And there are more detailed probing questions in the instructions that you should have received by email. But I'll also put the set of instructions in the chat area. So it's important to know that you don't need to rewrite the cases, but what would you say to a person who wrote this assessment in order to make this assessment less biased? I put the cases in the chat area as well if you want to download the file. These are the cases themselves. You can also take a photo of this while it's up, though we're not going to read it right now. So in a second, we will put you into even and odd numbered breakout rooms, and you'll be focusing on the cases. Will take about 20 minutes, so a good amount of time, I think, in order to focus on the cases. And then one other task I want to add is, if you have time, if you could talk about not only what you might say to the individual who wrote this assessment, but if you could think about some systematic ways of addressing bias in narrative assessments at your institution. So across the boards, what would you do on a systematic basis in order to create change? So if you have time for that discussion, that would be great as well. Any questions before we go to breakouts? Okay, we'll bring you back in 20 minutes, and Gary's going to, I think Gary will send you a warning, right? Okay.
Yes, I will. So pay attention to the room number that you're getting assigned to, because that'll tell you the even or odd.
So good so far. Timing is going great.
Mhm.
I think so. I think it's going really well.
Yeah. So I do see that there's a question in the chat where I didn't catch it when they put it there, but I'll answer that question. Do we know anything about the evaluators?
Right.
So there are some things I can point out about the limitations of that study. So maybe what we'll do is first get, have the discussion from the breakouts.
Right.
And then I'll just quickly talk about some of the limitations of the study that we looked at to go back to that question.
That seems good. Let them.
Okay, welcome back, everyone. Seems like everyone's back. So I'm putting the cases back up on the screen for reference. I do realize that there was a question about the study that we looked at, the Rojek study, which I'll answer at the end when we have a Q&A time. And Dowin is also going to talk a little bit at the end about if you want to conduct studies on narrative assessments, what are some things to think about? So we'll come back to that. But for now, I'd like to hear a little bit about what you talked about in your breakout rooms. So starting with case one, if someone from an odd numbered room could share some of the conversation you had, that would be appreciated.
I'm happy to share. We were in group 11 and our conversations initially focused on our interpretation of the case and sort of the issues that we saw in the case. And then we moved to advice that we would give to this faculty member. So acknowledging up front the intent of the letter writer to provide positive feedback, to encourage the person to align feedback to milestones to help the learner improve, and also inform decision-making of others, such as a clinical competency committee, to share examples of feedback with a faculty member that demonstrated best practices, to have a rubric or a guide or specific questions in mind when completing an assessment to help identify potential implicit biases, to focus on observable behaviors and to keep comments to those behaviors only, and then to try to avoid hearsay and narrative feedback. And I don't know if the group has anything that I omitted. Please feel free to fill in.
So anyone from the odd numbered rooms, do you have anything to add to that? Or what in particular was the problem with this particular case?
So I think we were in breakout group 5, and we talked about how they were primarily evaluation of letter use grindstone words and personality attributes of Melinda, and very few competence words. Let's see, we had talked about reframing, they made comments about how helpful she was in pitching in. And we thought that perhaps adding examples of how she pitched in, what was it that she did, and not just that she pitched in. And evidence to say why we made that little general statement. We also talked in our group about grading committees and having decisions being made by more than just the clerkship director or just the program director. And Monica, I'm sorry, I just saw your chat after we broke back into the big room, but you were talking about something with the narrative reviews. And I'm not sure that I fully got all that, what you intended. Did you want to add something about that, Monica Cuddy?
I can. I think it was also mentioned somewhat similarly in the first group that reported back. I was just thinking that almost from an assessment perspective, if you think about the narrative review and clearly sort of identify the unique information that is supposed to be gleaned from it. So what is the actual purpose of the narrative review above and beyond other measures? That if that's sort of clearly defined and understood, that may be part of a way of thinking about a standardization of sorts, but more about sort of what is the content supposed to be about and having that be clearly understood. That was it. It wasn't a huge point.
Oh, thanks.
One thing that group number 3, someone notices that as a reader, it sounded like as though this person hadn't even observed the resident at all. And I thought that was a very interesting observation. And our group brought up many of the same points the other groups have brought up.
And that's sometimes an issue of, say, clerkship directors who have to actually summarize some of the things they've heard from others. They're not necessarily the direct observers, but they have to summarize. They have to write the evaluation narrative. So I have a slide that's coming up that may be helpful in that regard if you're a clerkship director. Some tips for you as well. So we heard from groups 11, 5, 3. Anyone from the other odd number groups have anything more to add to what's already been said? So there's a lot of good points that were shared. Maybe what I could do is listen to the recording. So it's good that we're recording. And I wrote some down, but maybe I can make sure that we're pretty comprehensive in coming up with the tips that emerge from the discussions, and then send that to Gary, who could send that to everyone as an addition to the materials we've given you. So I want to move on to case 2. Could we hear from some of the even numbered rooms?
Hi, so I came from group number 4, and the first thing that our group picked up on was the very last sentence, being compared to the other students. That's just not that measurable, and is just laced with bias. And then tying that with the first sentence as well, you really just sandwich this case with bias.
Great. Thanks, Aaron.
Jimmy from group number 2. We had the first same impression as was presented by Aaron, I think. We also they used a lot the word seem. They seem like, and it felt like the whoever wrote that assessment hadn't really observed the candidates. So instead of using seem, we would use like more assertive language and give concrete examples. Make the appraisal more skill-centered. Right now, it's more about that person not knowing a lot and then catching up. And maybe instead of, and here it depends on what the expectations were about that level of knowledge, but instead of using caught up or catching up, use something like it helped him build a solid knowledge for a solid knowledge foundation in the specialty or something like that, but and focus our biggest, I think, observation was that the assessment could have focused much more on what Brendan actually did and on factual example that were more skill centered.
That's great. Pretty comprehensive too.
The other Gary, we're in room 8. And just kind of building on what Aaron and Jimmy said, we did kind of feel like, as Aaron pointed out, that the first and last sentence sort of bookended this statement with evidence of bias. And then what was internal to that, even if you took the first and last sentences away, it was essentially a weak narrative review, because as Jimmy pointed out, we really need to be getting very specific indications of what's the evidence of that enthusiasm. How is it we see his learning from reading indicated in the work he did during the rotation, et cetera, which made us think that one of the things we might be thinking of institutionally in this case is making sure we're giving good guidance to evaluators on what a strong evaluation is, clear prompts for what should be included, and maybe even examples of exemplars versus weak ones, including weak ones that include evidence of bias as part of the training or preparation for the evaluation process.
Great. So training, maybe implicit bias training as well. Maybe I've been hearing things like using intentional narrative language, and maybe creating a list. And in the Rojek study, there is a list of, in the appendix, if you go to the appendix, of terms that designate competency rather than personality based. So, maybe distributing lists like that on a systematic basis, blind review of narrative comments so that the person reviewing doesn't know who the student was. These are all systematic things that I think could be done. Anything from groups 6 and 10?
Yeah, this is Christina from group 6. Our group was talked a lot about the facts of that last sentence, as was echoed by others. Not only that, this is an international student, visiting student, but things like, the student came in with a high level of enthusiasm, but, didn't have a strong foundation of knowledge or appreciation for the specialty. What does that really mean? And how is that even relevant for this student? There was no milestones or ideas of how the student had displayed any competencies other than, read a lot and was really enthusiastic. And at the end of the day, what does that really mean? Because you have students coming in who are enthusiastic and may not have a lot of knowledge about a specialty, but that doesn't really dictate their competency. And also on the international side, about the fact that, it brought up the communication, not only perspectives and implicit bias that might be within the narrative, and the lack of some real specific competencies being expressed, just communication. Maybe the student was really ahead of his class. It just took him longer to maybe get through the material or read a lot. I mean, it really spoke a lot to our solutions. For basically, would be a good case for faculty development. It would be a good case to really look at those things, like what another group brought up. Seemed like he did this, seemed like he did that. Well, did he or did he not? And what does that mean?
Yeah, it seemed like a lot of assumptions to me. A lot of assumptions were made.
Yeah.
I can briefly jump in for group 10. I don't think we have a whole lot to add other than, we basically agreed with what's been said before. We thought the reviewers should avoid talking about themselves and really, that they recommended this, and really focus on the student. For example, the student, read a great deal extra. It seemed like a very bland, non-informative, overall weak recommendation for somebody that supposedly did a clinical sub-I. And similarly, the idea that whatever the line was about a student of this background is really sort of very biased and negative, and totally uninformative in terms of the student's evaluation.
Yeah. As I said, lots of really good points. So I will listen to the recording and do a textual analysis myself, and send back to you some of the really good points that people raised in terms of tips to eliminate bias. So what I'd like to do, thanks all for sharing. Sounds like you had some very good discussions in your groups. What I'd like to do is I'm just gonna breeze past these two slides. This one are some tips for those who are tasked with summarizing learner assessments, such as clerkship directors that I mentioned a bit ago, and they're pretty self-explanatory, so I'm not going to spend time on this. And then this is also for those who might be designing questions to draw narrative feedback from faculty, some of the ways in which you can actually form your questions for faculty to answer with respect to learners. So again, I'm not going to go over this, but I want to give Marty some time to move into thinking about quantitative assessment and biases that are embedded in some quantitative assessments. Marty?
John. So yes, we've been talking a lot about narrative and qualitative assessments, but bias is surely not limited to that arena. Quantitative research can have all sorts of biases as well. And I'll just give you a very brief viewpoint of how I think about this, which is there's things called systematic bias and random bias. Random bias is something that occurs all the time. It can be minimized, and we really don't worry so much about it at all. What we worry about is systemic bias. And in research point of view, there's three main topics under systematic bias, which is selection bias, measurement bias, and exposure bias. So very quickly, selection bias, who you're picking. Groups can be different. There's non-responders. All these things can definitely affect the amount of bias in your results. Jumping to the far right, there's exposure bias, and that's more or less a timing thing is probably the largest thing when it comes to evaluations. But I want to focus, and I think the most important for this group will be measurement bias. How is it that students, and for that matter, faculty, are measured? So there's 6 main measurement biases in my view. Just before you go there, John.
Oh, sorry.
That's okay. So there's these 6 biases. There's instrumentation bias. There's insensitive measure bias, expectation, recall, attention, and verification. And we're going to focus on 3 of these that are most applicable to this group. Okay, John. So measurement bias includes all those issues that relate to how your outcome is measured, what you care about is being measured. So there's this first, probably largest, is data collection bias. So as a rater, my personal beliefs can actually influence what data or how I collect data or what data is actually collected. And that's very important. So ways to minimize this is you need to think about, has the tool or instrument that's being used been assessed for validity and reliability? Really key points. Think about it. Take a step back and look at the data acquisition. How is the information being gathered or the data being gathered? Think about ways, in fact, that system might be flawed, how it might be actually allowing bias to creep in. And also equally important is, are the faculty, if they're the ones doing the ratings, being taught what the terminology and language used in the assessment actually means? Because people can see or read the same word and have different takes on it based on their personal experiences. So it's really important to try to have people think of the wording in the instrument the same way. There's an expectation bias where graders will err in measuring data towards their expected outcome. So sort of in that narrative, the second narrative thing that we just walked through case, it seemed like that grader might have had an expectation that an international student may not be as good in whatever clinical skills as Americans. I don't know. But if that's the case, that person may, even in a quantitative study, actually wind up, whether they realize it or not, downgrading the score for that person because they expected them to be a little bit lower. And recall bias, and this one's actually interesting because we've all heard about recall bias, but often we recall positive events more than negative ones, which is kind of contrary to what I would have thought before I started to read some of the literature. So, but again, so the further away you are from timing of a student and now you're going to rate them, the more that recall bias jumps in, the more that you can create a bias between ratings of different students. I like to call this one, and others have as well, the objectivity myth. I mean, a positivist or the classical test theory perspective is that for every learner, everyone you're rating, there's actually a true score. This is actually their score. Now, we don't know that. We try to get at it through assessments and instruments. But so there's a true score, and then there's some sort of error. We don't know what that error is. But that's a statistical, classical statistics type way of thinking about these things. But in medicine, I think it's really important, and we're trying to teach the students to solve problems as opposed to just saying 2 + 3 is 5. There's an exact answer. I think we're more looking at how are they thinking? Are they going about the process properly? Are they considering all the things correctly? So the concept of an objective true score, which is part of the assessment tool scoring, true score plus measurement error, is actually an area that needs a little research because I think it can be questioned. I'm not sure that there's an absolute true score in the way that statisticians would think about it anyway. And lastly, and very importantly, I think to this group, is that it's not just us evaluating students, but students evaluate us. And all the same biases can creep in. For instance, there's a wonderful study by Mitchell and Martin where there was an online course given, the slides, the presentation gone through and taught exactly the same way by a female and by a male instructor, okay? And then the students, after hearing this course, evaluated their teacher on an ordinal scale. And they evaluated them on 5 different characteristics. The first one were instructor characteristics, which included things like effectiveness, fairness, encouragement. Another one was presentation. How well did they present the information to the students? A third one was the course itself. What were the expectations? How did they experience the course? How much was the workload? Was it too much, too little? And also was the technology, was that useful, however it was utilized in transferring the information during the lecture? There was also a 5th one, which had to do with administrative issues, which meant questions about how easy it was to register for the course and being advised. But these things were totally outside of the instructor's influence, right? The first 4 are totally within the instructor's influence, their characteristics, presentation, course, and technology use. What they found was that in the administrative area, there were no difference between male and female instructors. But then again, those instructors had no influence on this. It's the administrative getting into the course. However, for all 4 other characteristics, male instructors had higher scores, ordinal scores, than the female instructors. It's the exact same course. They taught it the exact same way. They went over it, so they made sure they did that. And so there was absolutely some sort of bias represented in this evaluation of instructor by the instructor gender. Now, the limited, I didn't see any information on who the students were. I'm assuming they were both male and female. So I can't understand if there's a correlation that way, but it surely looks like there's a bias and that female instructors are being graded more severely and lower. The other thing that student evaluations of teachers almost always have as a problem is that they tend to have very low response rates. It's not like everyone taking the course rates the instructor. And so when you start to get relatively low response rates, we often worry about how representative is that actual score, because certain people may be motivated because they either like or dislike the course more than the opposite. And so your scores may not really be truly indicative of your teaching. So I think that's really important because these evaluations affect our career paths. So it's really important to understand this can be happening. And I think it needs a lot of research to understand how it is actually affecting us all. John. Questions? Questions? Okay. Yes. We're back.
So thanks for your attentiveness. There will be some time for questions. I did want to answer a few questions that were raised in chat. Somebody asked if we could share the link to the studies that were discussed. The links are in the PDFs. If you got the PDF from Gary in the mail, they should be active hyperlinks to each of the studies. If not, they're pretty easily found online, and all of them are open access that we've included in the slides. Somebody asked also about drawbacks of the study that we looked at in terms of the charts that we looked at, and there certainly are drawbacks. Someone asked in particular, what were the demographics of the evaluators, of the assessors? And that is a drawback of the study. We don't know the demographics of the assessors. So that's one thing, if you're thinking in terms of how to conduct studies like this, it would be very useful to have assessor demographics as well. Another drawback was that it would have been nice to have looked at intersectionality. I was curious about how gender and race and ethnicity worked together, and we didn't see that from the study. Of course, all studies have, their drawbacks, and they also need to have parameters. So I'm not trying to criticize the study. I'm just saying in terms of thinking about other studies, future studies, that's something that might be very interesting to look at, particularly in the day and age that we're in, where intersectionality is discussed a lot. One of the things I pointed out was that, we don't know what Spanish meant in the URM analysis. It could have pointed to a competency. So looking at single words may take things out of context, so that maybe a phrase analysis or single word terminology analysis coupled with some further textual analysis might be good for future studies. We don't know how the individual assessments in the clerkships translated into what went into the MSPEs, which would have been good to know. And Dowin may have something to say about that because his study actually did look at language in MSPEs. And of course, there were only 2 institutions represented in the study. We could have more institutions involved, though there were a large number of evaluations, which I think is the strength. We weren't able to link individual students across the clerkships, however, so we don't know if there's any kind of continuity or pattern to the way in which individual students are evaluated. So those are some of the drawbacks that I saw. Dowin, do you want to talk about, if we wanted to conduct studies like this, what might some other things be that we think about?
Absolutely. And John, I think you bring up a great point in terms of additional information and exploration of who the evaluators are, be it in terms of number, be it a single evaluator versus a group, and also just demographic composition of the evaluators would be important too. I think some data that we already have from Dr. Santon that she published in Academic Medicine a few years ago, looking at gender disparities in evaluations, showed that groups such as the Clinical Competency Committee seem to have less bias than when we look at evaluations where there's just one evaluator and maybe one trainee. Additionally, looking at the composition of the evaluators might inform possible interventions, such as, again, having a committee or increasing maybe the racial and ethnic diversity or gender diversity of that evaluation team. I think another area to look at is that we've already shown that there are disparities both in terms of qualitative analysis and quantitative evaluation, but I think it would be important to further explore how these differences manifest in outcomes in academics later, such as are these differences associated with withdrawal from residency, transfer from residency, maybe chief residency selection or graduation on time. I think all those additional outcomes would be interesting to explore.
One last thing, and then we'll let you add comments or ask questions. You'll notice that we didn't talk a lot about faculty evaluations in the qualitative part of the discussion today, and that's because there are very few. In fact, I'm only aware of one that was conducted by a group at Penn of gender bias language in assessment of teaching of teachers. I think there's a whole area of study that this group might be interested in, or members in the group might be interested in conducting. I think we need a lot more understanding of how bias in assessment, in narrative assessment of faculty evaluations, and of probably in letters, in support of or reviewing faculty contributions need to be done. So if this group wanted to do a group research study, I think there's one to be had there. So I'm going to stop there and then open it to anyone who has comments, questions for us, questions for each other. Thanks for your attentiveness as well.
I'll start with a question if I can. Can you hear me?
Yes.
So Dowin, you mentioned this, and I wonder whether there's consensus in the practice environment, not necessarily in the literature. Not feasible, how it's not effective. How, I'm missing the word, but can we, as a committee or a group of people, adjust, rephrase, recraft evaluations, narratives, as you were talking about committees? Is that a concept that is well validated or understood? I guess what I'm trying to get at is it okay to have a group modify what an individual, let's say clerkship director, has said for the benefit of reducing bias and streamlining and making more effective the evaluation? Sorry, I didn't phrase it better, but that's what I'm trying to get at. Thank you.
No, thank you for that question too. And I think that's a great point. I do want to clarify that I don't think the goal of the Clinical Competency Committee in and of itself is to go back and redo some of these evaluations per se. I think one of the benefits of the Clinical Competency Committee is it's a second set of eyes that also has experience with that trainee. So perhaps maybe there was an interaction that maybe didn't go well with the trainee and evaluator, or maybe the evaluator wrote something that just seemed inconsistent with how everyone else knew that trainee. Then I think the Clinical Competency Committee could add additional perspective that could potentially rephrase or kind of alter that statement. But I think the goal of the Competency Committee would be to add additional context and information as opposed to just reframing something that was stated, if that makes sense. And again, I think that's important too, to potentially have diversity on that clinical competency committee. As an example, when I was a resident, not only were there program directors on that clinical competency committee, but there were faculty of color, there were nurses, and there were also people from the community who may not necessarily have interaction with us in a clinical setting, but could also just give a different perspective, such that even if there were biases in that group, perhaps other people's experience could mitigate those biases. But again, I don't think the competency committee should go back and deliberately try to change what's written just for the sake of the appearance of reducing bias.
And what might be more pertinent in Charles' question too is what I raised earlier: do clerkship directors, or should clerkship directors actually change, some of the tone or the wording of the assessments that they're reviewing, to include in the student's grade, or in the feedback to the student, or in information that goes to the that may go to the MSPE? I think that's a big question. Do you change assessment in order to reduce bias? Do you change what the specifics of assessment in order to reduce bias? I don't know if anyone here who is clerkship director who's thought about that question might want to chime in, but I think that's an important question.
I mean, I would just chime in and say, like, it would make me uncomfortable to change it. I think it should be used for feedback. I think clerkship directors have a responsibility, at least the way we're set up, to review the comments and to, use specific examples to feedback to specific individuals. But I would personally not want to put that in the hands of, at least in our structure, that would not be appropriate. I'd love to hear other opinions.
So Judith, let me clarify. Would it be appropriate for a committee to feed back to the director to actually alter the language so that it would reduce bias, or just to let them know for the future? I mean, I'm trying to get at, should we change and alter when there's obvious bias or obvious the issues we talked about today, or should they be left alone?
I mean, we have pause points like built into our system where we say, like, review these, and it wouldn't be the responsibility of the clerkship director to change, but it could be the responsibility of the clerkship director to speak to a person and say, would you want to, let's talk about this? And certainly there are opportunities to feed forward and, to a clerkship director, or feedback to a clerkship director and say, listen, let's talk about this, and not just, discuss it, like what would be better, what would be a more appropriate way of saying this. But we've introduced pause points for the purpose of that. But again, like, it has, in our system, it would be relying on the individual, because it's written by an individual faculty member or resident, so we'd want the voice to be theirs. And we do that systematically. Like, we have them review all the comments so that we're not introducing a new form of bias by just picking out a few.
Eve raises the question in the chat on heading towards the direction of grading committees. Do you want to say anything about that, Eve? Or
well, we have established grading committees over the last couple of years, and I was just curious if anybody had experience with that, and whether we think that can mitigate bias. And maybe it depends, because we were talking about doing things within our systems, rather than just individual faculty training, or in addition, maybe a both end kind of thing. And then how do they function? Because it's different than the residencies, where you just have to say, yes, we're going to continue to pass this person on to the next year. This is more like actually determining grading and how those functions, how they're trained, whether they mitigate bias, and those sorts of things.
Speak a little to that from Dell Medical School. Gareth Gingell here. We have grading committees for all of the clerkships, and we're just now undertaking kind of a bias analysis to look at what's going on at the individual evaluation level versus what kind of comes out of the grading committees as well. And we have actually seen a mitigation of bias both for the quantitative as well as some of the qualitative measures that are coming out of grading committees compared to the individual evaluations that we see. So I think there is potential. And I'll say that's bias across both gender as well as looking at URM status as well for students. So the grading committees do seem to mitigate some of that, both numerical as well as qualitative bias, but it's coming back to how does that happen? And right now, while we have the idea of what the charge is for each one of the clerkship committees, we don't necessarily have an on the ground analysis of like what happens in the moment when those kinds of decisions are being made. So that's kind of a next step in our process of looking at those evaluations is how are those decisions being made on the ground to look at bias mitigation.
And I could also see them addressing a number of issues that come up, which is, grader differences, somebody's a hard grader, somebody's an easy grader, the student happens to get the hard grader. Also site issues, are the sites comparable in terms of assessment outcomes? It'd be super interesting to see all those things and how the committees are trained, what works, what doesn't work.
Other questions or comments? We have about 3 minutes. I put the Penn study that I referred to, resident assessment of teachers, in the chat area, but I'll also send it to you I'll send it via Gary, as well as the great tips that you've been raising throughout this discussion. Anything else?
To be thought only. As a practicing AR doc and as a clerkship director in EM, I would love to see the assessments written by practicing physicians saying these are the skills that we need to see and be very specific, can suture to this level, interprets blood gases to this level, very specific. I think that whether it help with gender bias, I don't know, but it sure would help with the evaluations because what I get now is just a bunch of blither that looks like it was written by Dilbert.
I think to the extent that we could move towards competency language, it eliminates bias, but it just improves evaluation in many different ways. Thanks for those who are putting links to other studies in the chat area. Maybe we can leave the chat up for a few minutes past 1:30 just to allow people to scroll through and download anything you might want.
The chat is actually recording as well, so I can make sure that it's included when I send out a notice when we get things loaded on our YouTube channel.
Great.
Well, thank you all.
All right, well, this may be a good point to end. So thanks for your time. Thanks for hanging in there for an hour and a half. It was a pleasure to be with you.
Yes, thank you all. An hour and a half on Zoom can be a long time.
Mm-hmm.
Thank you.
Will this recording be